My name's Ashley, and in this lecture we're going to talk about the basic cardiac views and echo and life support. So during the course of this lecture we'll talk about our probe selection, we'll talk about how we obtain the 4 standard cardiac windows, we'll talk about why we perform an echo in cardiac arrest, how we go about actually getting this echo done during the cardiac arrest, and then we'll talk about some of the things that we might find. So we'll talk about cardiac standstill, and we'll talk about some of the key reversible pathologies that we may be able to identify. We'll finish off by talking a little bit about the inferior vena cava, how we image that, and what we can interpret from those images. So for the echocardiogram, we're going to use the phased array transducer. Very different from the linear and curvilinear transducers in the way that it forms an image. The phased array transducer is made up of multiple small elements, each of which will emit their ultrasound wave at different times, so a phased array of elements. This allows the beam to be steered in different directions, and in that way we can scan a very large sector whilst at the same time maintaining a very small footprint of the probe. And this is essential given that the heart sits behind a rib cage. So when we talk about the 4 standard echo views, what we are talking about is the subcostal view, the 2 parasternal views, so this is the long axis view, the short axis view, and then we talk about the apical 4-chamber view. During cardiac arrest we aim to get at least 2 of these views. So on this slide we see some schematics of how we position the probe and where we position the probe. So we'll start with the subcostal view, and I'll demonstrate that on the skeleton here. So we want the probe marker positioned towards the patient's left hand side, so towards 3 o'clock on the clock face, and we want to bring the probe into the subcostal space, and we want probe marker to be orientated towards 3 o'clock, and we want to direct our probe towards the patient's left shoulder, and we'll be scanning through the liver looking at the heart. To look at the IVC, we just rotate the probe anti-clockwise so that the probe marker is towards the patient's head, and then we'll see the IVC coming out of the right atrium. When we talk about the apical 4-chamber view, we need to place the probe at the apex beat, so somewhere around here in your patient. Again, probe marker towards 3 o'clock on the clock face, and then we bring the tail of the probe down so that we're pointing the probe towards the patient's right shoulder, and this way we cut through all 4 chambers of the heart. So moving on to the parasternal views, we want to place our probe between the 2nd and 4th intercostal spaces. That's shown here in the schematics on the slide, and I'll demonstrate that here on the skeleton. So 2nd to 4th intercostal space with the probe marker oriented to the patient's right hand shoulder. Once we've obtained the parasternal long axis view, we can rotate the probe so that the probe marker is then pointing towards the patient's left shoulder, and we'll have rotated straight into the parasternal short axis view. So now that we've seen where we position our probe and how we get those images, I'm just going to talk you through what we see in those images, so what we see on our screen. On this slide here, we can see the slice through the heart that we take with the parasternal long axis view, and we can see the corresponding schematic ultrasound image. So what we're looking at here is the left atrium, the left ventricle, the left ventricular outflow tract, and the right ventricular outflow tract. We can also see the mitral valve and the aortic valve. Beneath the structures of the heart itself, we can see the descending aorta. Here we see a case where we see the parasternal long axis, and we can see the left atrium going into the left ventricle. We can see the anterior mitral valve leaflet, and then we can see the closed aortic valve and the aortic root, and above that we see the right ventricular outflow tract. And here we see this as a video. So we can see the heart is beating, and we can see that that mitral valve is opening and closing, as does the aortic valve. So once you're happy with your parasternal long axis view, you rotate the probe so the probe marker is then pointing towards the patient's left shoulder. As you rotate the probe, your long axis view will turn into your short axis view. And what you should see is a round left ventricle with a crescent shaped right ventricle around it. There are multiple planes when you're looking in the short axis. You can have an aortic plane, a mitral plane, or a papillary muscle plane, and you can even scan all the way down to the apex. At the aortic valve level, you'll see the aortic valve in the center of the ultrasound image. Below that, so deeper to that, you'll see the left atrium, and then wrapping around that aortic valve, you'll see the right side of the heart. So the right atrium, the tricuspid valve, the right ventricular outflow tract, the pulmonary valve, and then the pulmonary artery. As you start to rock the probe downwards, you then enter the mitral valve level, and this is also called the fish mouth view. And what you see is an opening and closing mitral valve within this round left ventricle and the surrounding right ventricle, which is a crescent shape. Some people call this the croissant and the donut. And you should have a nice round donut and a nice crescent shaped croissant. As you go further down and cut through at the papillary muscle level, you'll see two papillary muscle bulks, but otherwise the image will be very similar to the mitral valve level. So moving on to what you'll see in the subcostal view. So you've got your probe positioned in the subxiphoid space, slightly to the patient's right hand side, so that you're using that liver as an acoustic window. And what you'll see closest to the top of the image is the right side of the heart, and deeper in the image you'll see the left side of the heart. You should be able to identify almost all of the pericardial space, and this is a good view for looking for pericardial fluid. Here's a still image of the subcostal space, and at the top you see the liver, so we're using that liver as an acoustic window, and beneath it we're seeing a very small triangular shaped right ventricle, and beneath that, so deeper in the image, we're seeing that left side of the heart. And here is a video of a subcostal view. So moving on to the apical four-chamber view. So this is the window at the apex beat, and we're, as you can see in this schematic here on the slide, we're shining that ultrasound beam towards the patient's right shoulder so that we get a cut through the heart that allows us to see all four chambers, and we can compare the right side of the heart to the left side of the heart. The optimum image will have the intraventricular septum going down the middle of the screen. Here we see a still image of the apical four-chamber view, and we see the right side of the heart, we see the left side of the heart, and we see the septum running down the middle of the image. And here we see that as a video. On the left-hand side of the slide, you can see the smaller right ventricle, and on the left-hand side, you can see the larger left ventricle. So we've briefly run you through how to obtain the four standard cardiac views, and now we'll talk a little bit about how we perform an echo in cardiac arrest and how we use echo in cardiac arrest. So we can use echo in cardiac arrest to prognosticate, so we know that cardiac standstill identified on an echocardiogram is associated with worse outcomes and reduced return of spontaneous circulation. We can then use echo to identify reversible or treatable pathologies, and this ties into the 4 H's, the 4 T's that you'll all be familiar with from advanced life support. Finally, we can also use echo to confirm the cardiac arrest rhythm, and there's lots of published evidence to suggest that echo performs better than just ECG in determining the cardiac arrest rhythm. I think it's important to stress at this point that the evidence for echo in cardiac arrest is limited, but it is expanding. And at the moment we should be using it as an adjunct to advanced life support, and we should be using the findings from our echocardiogram as part of an integrated approach to treating these patients. So how do we do an echo in cardiac arrest? Well, the first thing to say is that performing an echo during a cardiac arrest is notoriously difficult. The timing of the echocardiogram is important, and we also have to do that echocardiogram at speed. We want to do it during a break in CPR, but we don't want to delay the resumption of CPR or the start of CPR. We know that a cardiac arrest is a high octane environment. There are lots of people in the room, there are lots of emotions in the room, and it can be very difficult not just to access the patient, but to perform an echo within a 10-second pulse check. And we know that echo delays the resumption of CPR. There have been a few papers that have been published in the last few years that have all shown that doing echo during cardiac arrest delays the resumption of CPR after a break. However, all of these studies suggest that echo is trainable. So with training, that pause can be reduced. So how do we avoid delays in CPR? So the first thing I would say is approach the patient whilst chest compressions are ongoing. So towards the end of a cycle of chest compressions, wheel in your machine and place that probe on the chest. I tend to start with the subcostal view because it's the most easy to obtain view. And what I'll do is I'll roughly get a view whilst chest compressions are ongoing, and then once the pulse check has started, I'll optimise that view, save some images and wheel the machine away. This means that I'm limiting the amount of time that's being spent doing the echo and less likely to cause delays in CPR. I think this is one of the only times where you really want to become task focused, and I would advise strongly not to be doing any other jobs during this CPR. So don't do the echo if you're the team leader, and don't be picking up other tasks other than the echo. So we'll start with talking about cardiac activity or cardiac standstill. So the first thing we want to do is identify whether that heart is beating, and you should try to identify this on two separate views. You may see that the valves flutter in response to fluid boluses or drug boluses. That does not count as cardiac activity. Cardiac activity is organised myocyte activity, and you should see all of the ventricles contracting. Here we see a video of cardiac standstill. We see that the ventricles are not contracting. We do see some bubbles in the right ventricle and the right atrium, and this is either a fluid bolus or a drug bolus being given. The movement that you can see in this video is movement caused by my hand and my manipulation of the probe. There's no organised ventricular activity. So once we've identified whether there's cardiac activity or cardiac standstill, we move on to identifying any evidence of reversible pathology as a cause for this cardiac arrest. And this ties in with the 4 H's and the 4 T's that we're all familiar with from advanced life support. We may see that the patient is hypovolemic, and we'll assess this by looking at the IVC. We may see that there's evidence of a thrombus, evidence of a pulmonary embolus, and we might see evidence of cardiac tamponade. You may even use lung ultrasound to check for a tension pneumothorax. Finally, one other thing that we can look for is fine ventricular fibrillation. So sometimes we'll have a patient in front of us who appears to have a non-shockable cardiac arrest rhythm, and then we do the echocardiogram and we see fine VF. These patients may benefit from a shock. So here in this video we see an example of fine VF during cardiac arrest, and the most obvious fibrillating structure we can see is the mitral valve, but if you take a closer look you can see that all parts of the ventricular wall are fibrillating. So the evidence of fine VF was very subtle in that first video. Here we see that same video side by side with a case of asystole, and actually those changes that you see with fine VF are a little less subtle than first imagined. So one of the reversible pathologies that we will be looking for with our echocardiogram is cardiac tamponade. Now we won't see the physiological evidence of cardiac tamponade because the heart won't be beating, but we will see an anechoic fluid collection within the pericardium, and we can see that here in this schematic of an apical 4-chamber view. Here we see a schematic of a parasternal long axis view, and the blue rim around the heart represents the pericardial fluid. Now, one thing I will point out here in this schematic is that pericardial fluid sits above the descending aorta. If you see anechoic structures beneath the descending aorta, so deeper to the descending aorta, This represents pleural fluid, so fluid in the thorax. Even though you won't be able to see these signs of tamponade during a cardiac arrest where the heart isn't beating, I think it's only right to go through some of the physiological signs of tamponade. So what we see is collapse of the right-sided chambers, the low pressure side of the heart. So we see right ventricular collapse during diastole and atrial collapse during systole. And then we also see a plethoric IVC, so a big dilated IVC that doesn't collapse with breathing. So another of the reversible pathologies that we may see evidence of in our cardiac arrest echo is a pulmonary embolism. So the two things that we're primarily looking for are dilated right heart chambers and a plethoric, so a big non-collapsing IVC. Less commonly you may see clot in transit, and this refers to the presence of thrombus within the IVC or the chambers of the right side of the heart. One caveat to interpreting your cardiac arrest echo is that there's emerging evidence to suggest that right heart dilatation may be part of the pathophysiological sequelae of any cardiac arrest. So cardiac arrest caused by any other cause, not just pulmonary embolism. My take-home message from this slide really is that if you see a dilated right heart or a plethoric IVC, interpret that with all of the other clinical information at hand. So now we'll move on to showing some videos that are either taken during cardiac arrest or after the return of spontaneous circulation, all of which demonstrate right heart strain or enlarged right heart chambers. In this first video, this is after the return of spontaneous circulation in a young patient who had a cardiac arrest secondary to a PE, and we see an enlarged right heart at the very top of the ultrasound image. In this second video, in the same patient, this is a suboptimal apical 4-chamber view. Often you won't get the optimal view in cardiac arrest, but here you can quite clearly see that that right ventricle is much bigger than the left ventricle, more than a 1-to-1 ratio, which is what we are looking for when we measure the right ventricle. Here is another example of right heart strain causing the D-shaped left ventricle, this time on the parasternal short axis. And in one of these patients, we've taken an image of the IVC, and we see that that IVC is not collapsing with respiration and is more than 2 centimeters in width. This is a plethoric IVC and would fit with the right heart dilatation that we've seen in a case of PE. And here in the same patient, again, when we're comparing that right ventricle to the left ventricle on the apical 4-chamber view, we can see that that RV is much bigger than the LV, more than the 1-to-1 ratio that would be our cutoff. Here's a schematic that demonstrates the thrombus in transit. In the image we see that there's right heart strain, so the right ventricle is pushing into that left ventricle, same with the right atrium, and then we see this thrombus in the right heart chambers. In the video beside it, we see thrombus moving in and out of the right atrium and IVC. So we're going to finish off talking about the inferior vena cava, the IVC. So we've spoken about how we get to the IVC from that subcostal view before, but we're going to talk about that again on the next slide. We measure the IVC, so we measure the diameter of the IVC, and roughly speaking, the normal diameter should be between 1.5 centimeters and 2.5 centimeters. We also know that the IVC collapses with inspiration, and it should normally collapse more than 50%. When we see a small IVC, we need to consider hypovolemia as a reversible cause of cardiac arrest. And as we've mentioned before, if we see a big plethoric, non-collapsing IVC, we need to consider whether a PE or cardiac tamponade has caused this patient's arrest. So this slide acts as a reminder of how we obtain that view of the inferior vena cava. The easiest way to get to the inferior vena cava is to first start off by obtaining a subcostal echo window. So probe marking towards 3 o'clock, towards the patient's left hip, scan through the liver, and we obtain that subcostal window. At this point we can rotate the probe anti-clockwise until the probe marker is towards 12 o'clock or towards the patient's head. And what we'll see on the ultrasound machine is an image of the IVC as it exits the right atrium. Here we see a normal IVC, measured 2 centimetres away from the right atrium, which you see on the left-hand side of the image. The IVC measures 2.1 centimetres, which is within that normal range. Over these next few slides, we're going to see some examples of plethoric IVCs and some very flat IVCs. So this is the first cardiac arrest case where we see a plethoric IVC. Here's a second case, which is post-cardiac arrest. And here again we see a very big plethoric IVC, and we also see a distended hepatic vein. That's the vessel that's at the top of the screen running down into the IVC. So we've seen a few examples of very plethoric, large IVCs, and here we see 2 examples of very flat IVCs, where during inspiration the walls of the IVC are kissing, they're meeting, and that suggests that this patient has a very low preload or is likely to be hypovolemic. Here we see an M-mode image taken through the IVC. So we see the IVC over time now in that bottom part of the image, and this allows us to measure that collapsibility index. So as you can see, we've taken 2 diameter measurements, one during inspiration and one during expiration, and we measured that collapsibility index, and the collapsibility in this patient was more than 50%, so what we would expect in normal patients. So that brings us towards the end of our presentation on echo in cardiac arrest. We've taken you through acquiring the 4 standard echocardiogram views, and we've talked about how we do an echo in cardiac arrest, why we do an echo in cardiac arrest, and how we can actually do this in practice. We've then described and shown some of the reversible pathologies that we may be able to pick up using an echo in cardiac arrest, and we've spoken about how we can use cardiac standstill to prognosticate in cardiac arrest.